All right, class, here we go. We're going to start a journey on EKG. This is a journey that's going to last you guys predominantly the entire year. EKG is one of those topics that is one of the more important concepts for paramedics to understand, and it's becoming more and more important every single day. I'll say here that as we walk through this, you may have questions that come up. You are always welcome to send me an email or grab me, come down to my office, whatever we have to do to try to understand this as we move forward. It's one of the biggest topics that we have. Cardiac function in general is one of our biggest topics, and EKG is one of the largest subtopics of our heart-related conditions and our heart-related concepts. So at any point in time that you have questions or we need to delve into this more, make sure you let me know and try to get help early as opposed to later when we talk about this. So I'm going to share my screen and we'll jump into a couple of review topics and making sure we understand where we're going. And then we'll break these up into small little video segments over the course of most of the year. So hopefully you see this on your screen now. This is just a real brief where we're going and what I'm gonna hope for that you can do when this is all said and done. So we're talking about electrocardiography. We can't talk about EKG without also talking about the heart in general. So we'll be dealing with that as we go as well. But where we are and where we're going, just so that we're all on the same page. Some things that we all have in common: everybody has a heart and everybody dies. Cardiovascular disease is the leading cause of death in all developed countries and is the second leading cause of death across all developing countries, which means it's the first or second leading cause of death in all people on this planet. So it's important for us to understand the purpose of EKG and where it fits into what we are doing as paramedics. This is where we are as of now, as you've gone through your EMT and everything else that you've done in your life. You've kind of seen this kind of a thing. You've seen an EKG. You've seen some lead twos all over the place. Some of you are working with departments where you've had some experience looking at EKGs, at least minimally. And so we all kind of have this general concept of these little blips that we have, this P wave that we have here leading into a QRS and T wave. Some of you might be able to name all of those and what happens and where they come from in the heart. Some of you may not, but this is where we are right now, generally speaking. But this is where we're trying to go. What I want to do is to find a way for you to be able to approach any one of these. How do you start to approach this? If you have a patient that's displaying any one of these EKGs, what does that mean? And do we panic when we see this? It's common for us to be able to look at a single lead, like a lead 2, and go, hey, that makes a lot of sense. But then when we look at something like this one here on the bottom right, and we think, wow, that's just an absolute mess. Where do we even start? So by the end of all of this, you should be able to take an EKG like this, and you should be able to just whip out, for the most part, what you think the major concerns are and what you need to be thinking about with this patient. So this is where we're going. This is what we're trying to accomplish and where we're trying to go with it. So that's what I'm hoping that you can get. So without further ado, let's talk about some general heart-related concepts that lead into EKG. So let me share my screen one more time on this. Okay, you really can't do anything with EKG if you don't fully understand the heart. So I'm going to post some review slides as well on the heart. I say the review, they're pretty in-depth as well. And so depending on who your A&P instructor was, how well you paid attention in A&P2, that'll make a difference. So if in any of the review slides, there's a bunch of it that you don't remember, or that you don't remember being taught, or you didn't hit in depth, I need to encourage you to go back and make sure you have that nailed down. I'm happy to sit down with any of you if you are struggling with any of that. That material will be like the cardiac cycle, and what are the different ions and IF channels, and what's a common shape for an action potential of an autorhythmic cell versus a contractile cell. So a lot of your stuff that you got in A&P2, if you took your A&P at a community college, those will be things that you want to go back and make sure you review. So be sure to take a look at those notes, and if you have any questions, bring them up early so we can address those, because those are going to be pretty critical, and we'll be going over those on the assumption that you know that material. We're going to be mentioning or reviewing or expecting you to have that information as we move on into EKG. In addition to that, you also learned a little bit about the conduction system, and I want to take a moment to review that before we jump into the rest of the EKG stuff. When it comes to the conduction system, the electrical conduction system of the heart, the things that you should already know is that it's created to, or it has a cellular aspect that creates the electrical impulses in the heart that cause the mechanical action to take place. I want you to forevermore think of the heart as two completely different systems: the electrical system and the mechanical system. The electrical system is the system that is creating and transmitting the electrical impulse, and the mechanical system, or the muscle system, is the part of the heart that should respond to the electrical system, but they are two separate systems. You might have the electrical system working and the mechanical muscle system not working, or you might have a mechanical muscle system that is functional, but an electrical system that is not functioning correctly and leading to the actions that the muscles should be taking. So, so this process, it's an electrical chemical process that you should already start to understand, and we'll continue to go in depth into. The resulting electrical energy that we're talking about now is related to ions. So when we talk about electrical impulses, we're talking about the movement of ions, sodium, potassium, and calcium from one cell to the next through the gap junctions. So please make sure you review that. The electrical system is found within the walls of the heart. They are separate cells from the contractile cells. So we'll talk about autorhythmic cells and contractile cells. The autorhythmic cells are the cells that are generating these impulses, and the contractile cells are the ones with the actin and myosin and can actually contract to move blood flow. In addition to that, just be aware that even though I'm going to talk about autorhythmic cells and contractile cells, don't be confused. Every cell in the heart is autorhythmic. So even the contractile cells have a certain amount of automaticity in them, and they all have IF channels. So I'm not going to refer to them that way, but do remember that, because when we do get to the backup systems of a heart or some of our idioventricular rhythms, it is because those contractile cells are also autorhythmic that we're able to have that. The atrial myocytes are innervated by direct cell-to-cell contact from the gap junctions. That also is the way that the ventricles are working too, but there's a slightly different system down there that you'll recall. The internodal pathways transmit that impulse from the SA node to the AV node. We have those three pathways. We have Winky-Box, Thoral's, and Bachman's bundle. And remember that Bachman's bundle is the one that also transmits over to the left atria. If the words that I'm using here are a little bit foreign to you, or you don't remember them, once again, spend a little bit of time reviewing and send me messages on anything that you think is completely confusing that I need to spend a little bit more time on. in another video segment, because I can easily do another review segment if we need to. And then in the ventricles, they are innervated by direct cell-to-cell contact, like the atria, through gap junctions. But we also have the Purkinje system in the ventricles. The Purkinje system are autorhythmic cells that, for all intents and purposes, allow the ventricular contractile cells to all receive the signal relatively simultaneously. And that's also why we see the P wave be kind of small, rounded, and takes a little bit more time. And the QRS complex is very spiked and short in time, is because of this Purkinje system. So once again, kind of go back and review that Purkinje system. The sinoatrial node is our first section here of the conduction system of the heart. It's often referred to as the pacemaker. We find that in the walls of the right atria. So anatomically, you're going to find it up in the top right portion of the heart. Remember that as we talk about right and left, it's always going to be in relation to the patient, not in relation to what you're looking at on a screen. And it's pretty close to the junction with the superior vena cava. It is the main pacemaker of the heart. It initiates the signal. All autorhythmic cells can initiate a signal, but because the SA node is the most unstable of them, it tends to fire first, so it tends to have the control over the heart. It's the one that dictates the rate of the heart, and therefore the cycle through which all the pumping is going to take place. It'll initiate this sequence in depolarization that travels from one autorhythmic cell to the next, and from those autorhythmic cells into the contractile cells. And it should follow a pattern of upper right to bottom left. It should follow that pattern as long as everything is working properly. And the SA node is the thing that initiates all of that. It's the one that will alter signals to send to the other cardiac cells. And it is the one that is influenced by the nervous system and the endocrine system. There are, the other cells are also influenced, don't get me wrong. But when we talk about sympathetic and parasympathetic involvement, they have direct involvement on the SA node and other autorhythmic cells to either increase or decrease contractility, or increase and decrease the rate for which it's firing. So all of those things happen initially with the SA node and in concert with the rest of the autorhythmic cells. The internodal pathways that we have, Bachman's bundle, Winky-Bach's bundle, and Thorl's pathway are the internodal pathways that take the signals from the SA node to the AV node. It's also found all within the walls of the right atria, leading to the AV node, and the AV node, which you'll see in a minute, is also found in the walls of the right atria. The Bachman's bundle is the bundle that also has a pathway through the atrial septum to allow the left atria to also receive the depolarizing signal in addition to the right atria. We set these up as a pacemaker. You can kind of consider it like pacemaking in a pacemaking car, or a pace car in a race. It's designed that each autorhythmic area of the heart is more stable than the previous one, and that means that the more unstable, the more likely it is to fire. So the SA node is the most unstable. The atrial pathways are the next most unstable, then the AV node, then the bundle of his, then the bundle branches, and on down the line. So really think of it like a pace car in the sense that these different rhythmogenic areas of the heart are setting paces and following suit with whatever happens above them. So the AV node, the atrioventricular node, the AV node, is where the pathways, the atrial pathways, will come into play into the AV node. The AV node collects that signal. Its primary job is to delay the signal. So there's a series of anatomical channels within the AV node that cause the ion flow to slow down just a little bit. What that does is it gives the atria plenty of time to finish its contraction before the left ventricle gets its depolarizing signal to contract. That allows the flow of blood through the tricuspid and mitral valves to make sure that the blood can get all the way through to the ventricles before the ventricles start to fire. We don't want the atria and the ventricles to be firing at the same time. Otherwise, we get regurgitated blood through the tricuspid and mitral valves. So the AV node is also found in the walls of the right atria, pretty close to where the coronary sinus is. You'll recall that the coronary sinus is the blood vessel that is bringing blood back from the coronary arteries and the coronary arterioles to be reoxygenated. So it's found near the coronary sinus. It's also found near one of the leaflets of the tricuspid valve, so right towards the bottom of the right atria. And it is supplied by the right coronary artery. So if we have right coronary artery problems, we tend to also have problems with the AV node. The bundle of His is the only route of connection between the atria and the ventricles when we think electricity, ion flow. So the atrioventricular septum, the septum that separates the atria and the ventricles, is not excitable. It doesn't have any ability to have ions flow through it. So the only route of ion flow is through the bundle of His. Think of it like a tunnel or a bridge, but it's the only route of flow that ions can come from the atria into the ventricles. It starts at the AV node. So partially it's in the right atria, then it goes through the interventricular septum and ends in the right ventricle. So it kind of travels through all of those anatomical areas. It's supplied by the left anterior descending artery and the posterior descending artery both. And when we think of the AV node and bundle of His together, those two things together are referred to as the junction. So we'll talk about junctional rhythms, and when we talk about the junction, you should always equate that to both the AV node and bundle of His as a collection. So that junction starts with the AV node and travels through the bundle of His, and then is the bridge between the internodal pathways and the bundle branches of the ventricles. So the AV node and the bundle of His, again, make up that junction. We'll discuss more of that quite a bit later. Then we get into the bundle branches. We have the left bundle branch and the right bundle branch. The left bundle branch takes off from the bundle of His and continues to travel through the interventricular septum and then on into the left ventricle. It tends to be the first ventricular area to depolarize, and then often splits into 2 or 3 fascicles. I say 2 or 3. Everybody has a left anterior fascicle and a left posterior fascicle, and about 85% of people also have a septal fascicle. All of those branch off from the left bundle branch. The fascicles we'll talk a little bit about as well, but the left anterior fascicle, you see it on this picture, denoted here on the bottom. This is a 2-dimensional picture, so you have to kind of think of this left anterior fascicle as coming to the front of the heart, and this left posterior fascicle is going to circle around behind the heart as well. So the left anterior fascicle, it's a single-stranded fascicle, and the Purkinje fibers come off of it. There are Purkinje fibers that come off of it. It tends to innervate the anterior and the superior parts of the left ventricle. I know it looks weird on a 2-dimensional picture like this, so you just have to kind of bear with me on the picture side. It innervates the front of the heart, and the Purkinje system will kind of span out and make sure that it gets into the superior aspects of the left ventricle as well. And then we have the left posterior fascicle. The left posterior fascicle, if you look at the picture, it's very fan-like in its structure. That means that it's very difficult to block. So when we start talking about bundle branch blocks and hemi blocks, you'll see that the left posterior fascicle is one that's very, very difficult to block all by itself, versus the left anterior does not have that fan-like shape and is much easier to block. It also ends in Purkinje cells, and it innervates the posterior and inferior portions of the left ventricle. Again, it's just one that tends to be very difficult to block because of the way the fan-like structures work. And I'll talk more about that when we get into blocks and bundle branch blocks. And then in about 85% of people, we have the left septal fascicle, or sometimes referred to as the mid-septal fascicle. It generally arises directly from the left bundle branch as well, but it can come from the anterior or posterior fascicles. So where it can originate from is different in different people. We believe that it's responsible for the early depolarization that we see, and tends to depolarize about 5 milliseconds before either of the fascicles. So there's a little bit we don't know about it, but it's another one that doesn't often get blocked without damage to the entire bundle branch on the left side. And again, most people have it, but not all. And then we have the right bundle branch. And the right bundle branch also begins with the bundle of His. So the bundle of His will split into the two bundle branches, the left and right. The right bundle branch, however, ends in Purkinje system, in the Purkinje fibers. So it does not have fascicles. The Purkinje fibers come right off the right bundle branch as it goes down, and it innervates the right ventricle. It also innervates a little bit of the right side of the interventricular septum and the muscles that are found there. And then the Purkinje system, as I said before, the Purkinje system are some unique autorhythmic cells that tend to make it so that all the contractile cells of the ventricles within the left or right, depending on where those Purkinje fibers are, but any of the contractile cells that are attached to those Purkinje fibers, they're able to end up getting the depolarizing signal pretty close to simultaneously. And that's really important in terms of building up the necessary pressure, especially in the left ventricle, to overcome the pressure, the blood pressure that's sitting on top of the aortic semilunar valve and the pulmonic semilunar valve. So those Purkinje systems are what help to coordinate the ventricular depolarization. Now, the ventricles still have gap junctions and they still can fire cell to cell, but the Purkinje system makes them much more simultaneous and efficient. So if the Purkinje system is affected, the ventricles can still fire cell to cell, but you will see some differences on the EKG when that happens, and that'll become clear as we move forward. So the Purkinje system is what initiates the ventricular depolarizing cycle that hopefully will lead to the mechanical contraction and pumping of blood. When we talk about the automaticity and the conduction, each of the areas have certain conductive properties. The IF channels in each of these areas, albeit if you pull them out and look at them side by side, they look identical. However, the range of electrical impulse that causes them to function is a little bit different as you move down the heart. The SA node is what we call the most unstable. It has the widest range of electrical currents that it'll respond to, which means the SA node is more likely to start firing early on. Those IF channels will start to fire before any of the others. And then as we work down, when we get from the SA node down to the internodal pathways, down to the AV node, down to the bundle of His, each time we work down the line, they become more and more stable and take longer to fire themselves off. What that means is that each section of the heart's fire comes from the section above it, unless the section above it is not firing, in which case its own autorhythmic cells will take over and initiate the signal. So the SA node is the most unstable, and the ventricular myocytes are the most stable. And then the Purkinje system, again, is unique to the ventricles. It's not in the atria, and that is why we see kind of a different morphology between the P wave and the QRS complex that we see, and that I'll talk a lot about as we move forward. In terms of pacemaking, the SA node, if we rip somebody's heart out of their chest and set it on the table, like you see in Indiana Jones and the Temple of Doom, when the priest sticks his hand in the chest and pulls the heart out, and you're sitting there looking at the heart and it's pumping. Yes, the heart is autorhythmic and can function without the brain in terms of actual function. The brain can influence us to speed up, slow down, contract harder, contract softer, but it can't force the heart to work or not to work, only how hard it's working. So if we rip the heart out and set it on the table, the SA node is going to cause the heart to fire somewhere between 90 and 100 beats per minute. Now, most textbooks are going to tell you 60 to 100 beats per minute, and that's because textbooks do not rule out the parasympathetic involvement in our everyday resting life. But SA nodes typically fire between 90 and 100 beats per minute when left completely on their own. If the SA node fails and the pacemaker of the heart is initiated by an atrial cell someplace, that atrial cell will fire in the 60 to 80 beats per minute range. If the atrial cells also go offline and the AV node has to take over, the AV node is going to fire, the AV node and the bundle of His are going to fire between the 50 to 60 beat range. The AV node is a little bit faster than the bundle of His, of course, as we continue on moving down. And then if the junction is completely taken offline and all of our autorhythmic cells are pretty much kaput and the ventricles have to fire themselves, they tend to, if they can get organized, fire at about 20 to 40 beats per minute. As we move down the line and the cells are more stable, it takes them longer to actually initiate a signal, and that's why the heart rate is slower with those pacemakers on down the line. So again, think anatomically where things are located and think of them like a pace car. So that's just a quick overview of the conduction system. Most of that should be review for you. So I'm hoping that it is review for you. And if not, then it is time to make sure you jump back in and review that along with your anatomy and physiology of just general cardiac function. All right. This is going to end our first short video. Next one, I'll start getting into actual EKG components. So I'll see you soon.